Hello, my name is Heather Allore, and I am a biostatistician at the Yale School of Medicine and the Yale School of Public Health. And I'm here today to present the geriatrics perspective on the data analysis and study interpretation. When we think about data analysis and study interpretation, an appropriate analysis and interpretation includes design elements such as clustering. Are participants in nursing homes, hospitals, or physician practices? Hierarchies, such as within a hospital, there may be clinics or wards, or randomization strata, such as randomizing on frailty status. We might think about blinding and also outcome assessment, whether that's measured on the participant or their proxy, such as a health care provider or a caregiver, or whether we're extracting outcomes from administrative records. We also want to consider attrition and to whom the results can be generalized. When we're using age as a basis for analysis, that often fails to recognize the biologic states because we know chronologic age differs from biologic age. Age encompasses stages of development, maturity, and decline in biologic systems, and health can vary widely at the same age. The study of age groups or risk strata must be considered at the beginning with the study design and extend through the data analysis, interpretation, and dissemination of results. One way to really be looking at studying the lifespan is a life course analysis. The World Health Organization its definition is health is a state of complete physical, mental, and social well being, and not merely the absence of disease or infirmity. One approach to this is life course analysis that integrates biologic and social processes. And this approach examines health over time, and it involves considering how trajectories evolve and what's related to that evolution. One study that really looked at how earlier life affected later life outcomes was Cisco's and coworkers' study on looking at the role of early life educational quality and literacy in explaining racial disparities in cognition in later life. So we can see elements in the panel on the left that influence early life education, and then we can see how then they examine how that early life education affected outcomes in older age. Now, sometimes our data sets from a single source, whether an observational study or a trial, do not cover the whole lifespan. And so we may want to be looking at data harmonization projects. This is a small set of initiatives. The citation at the bottom shows a direction to see a much greater link of options for data harmonization. These include data standards, the COMET project, the core outcome measures, ineffectiveness trials, and a lot of common data formats that are suggested by major institutes and agencies. Now, when we have these larger data sources, whether harmonized or from healthcare system records or any large data sources, we might wonder really how are we going to analyze and interpret that? The Big Data to Knowledge program supports the research and development of innovative and transformative approaches and tools to maximize and accelerate the utility of big data and data science in biomedical research. This initiative has trained over 30,000 individuals in the use of these methods. There's over 250 educational resources. They have interactive digital media for analyzing biomedical data. They have software tools and methods to help researchers with these challenges. Now, one of the things we also find is that not only do we see variations in at any given age, but there's also other sources of variation when we're studying older adults. This is an example of adults with disability. Being independent is one of the most important outcomes for older adults, and it is a priority for their care. And so, this study of Courtney and Long and coworkers shows some variation across ethnicity and race. So when studies simply divide their cohort into white and non-white, it misses really the complexity and variation across races and ethnicities. So here we see 3 in 10 American Indian and Native Alaskans have a disability, while only 1 in 10 Asian Americans do. When we look at what could be risk factors for disability or outcomes important to older adults, we see that they also vary they showed obesity and smoking. So when we're thinking either about what may be related to outcomes important to older adults or also the variability in them, it's important to consider ethnicity and race. When we're thinking about other analytic considerations, we really want to think about the treatment effect. And when we have highly selective trials, these are usually efficacy trials, when we're looking at those effects, we should not extend them to populations that were not included. This highlights the difference between the estimate of the sample average treatment effect and the population average treatment effect. Selection issues don't arise when we're just looking at that sample average treatment effect, if there is no dropout and noncompliance. But if we want to generalize and obtain the population average treatment effect, the bias is a major issue due to selection. Other things we must be considering in our analyses are attrition that results in incomplete data. Studies that require multiple follow-up visits, long duration, or including high-risk groups may have higher attrition, non-compliance, and missing data, which can be problematic for the analysis and interpretation. Let's think about that definition of the World Health Organization that included social well-being. So we want to consider the neighborhood disadvantage, which is also measured with something called the Area Deprivation Index, or ADI. It's comprised of 17 educational, employment, housing quality, and poverty measures. It can be refined all the way to the census block, which is about a neighborhood of 1,500 persons. It's validated across the United States, and it's been created, refined, and validated and disseminated in the Neighborhood Atlas platform. So what's the potential for this geospatial metric of neighborhood disadvantage? Well, it's robust. It's generalizable to the full United States population, including Puerto Rico. It can be incorporated into predictive analytics. It facilitates mechanistic science across health conditions. It's privacy compliant, and it's a strong track record of applications, but mostly in Europe and other areas. It's also translatable. It's actionable at the person, community, research, and policy levels. It can guide outreach and targeting, particularly through the mapping aspects. It can influence the intervention design and implementation, and it's policy applicable. It's broadly eligible, adjustable, and there's resources. Those resources include that the National Institute of Aging did highlight them in a recent post. This is free for all. Another thing we may be wanting to do when we want to be looking not only at a single age group or part of life, but across a lifespan, is meta-analyses, which include systematic, critical assessment of the literature and data sources, and they form the body of evidence leading to the ability to generalize. Reporting guidelines for journals differ, making meta-analyses for age groups or other factors such as race, ethnicity, or deprivation or other social determinants difficult. Stratification is another technique that may be based on a risk of an outcome and should be pre-planned and aligned with the design and analysis. Risk strata may capture other relevant factors such as comorbidities and social demographic factors. Secondary and subgroup analyses face a risk of inflating the type 1 error due to multiple comparisons and should adjust the significance threshold. So then we want to interpret and present our report. So we want to do this on key age groups or the biologic stage, sex, race, ethnicity, coexisting conditions, or the pre-planned risk strata. We're going to want to report study limitations in the generalizing results and when the study cohort is not representative of the population with the disease. Publication should contain information on study enrollment, those who meet eligibility but decline to enroll. Dissemination or implementation would benefit from understanding the actual demographics of the study cohort. More knowledge on those who decline or drop out may inform whether a successful efficacy trial is ready for an effectiveness or pragmatic trial. When we're analyzing and interpreting data, we also want to think if we're presenting a relative treatment effect that we should include a measure of absolute effect. Children and older adults have long been excluded for concerns of safety, thus including adverse effects by risk strata or age groups or biologic and developmental stages may address these concerns. And for pragmatic dissemination and implementation trials, interpretation should include the degree to which results are generalizable to typical participants and or providers, institutions, communities, and settings of care. In summary, age encompasses stages of development, maturity, and decline in biologic systems. Health can vary widely at the same age. Life course analysis may capture exposures throughout the lifespan and provide us those trajectories that help explain differences across the lifespan. There are a variety of data harmonization and big data to knowledge projects that may address limitations of a single study or trial sampling. Health and risk factors vary by racial and ethnic backgrounds, as well as social determinants of health, including deprivation. There's methods to be able to address these. Stratification may be based on the risk of an outcome and should be pre-planned and aligned with the design and analysis. And lastly, for pragmatic dissemination and implementation trials, interpretation should include the degree to which the results are generalizable to typical participants and or typical providers, institutions, communities, and settings of care. Thank you very much.